Good morning, and welcome to this week's episode of the Ask Dr. Murphy series. My name is Katie Berg, and I'm a research study coordinator here with the Havey Institute. I'll be leading today's discussion. I'd like to welcome and introduce Dr. Robert Murphy. Dr. Murphy, how are you this morning?
I'm just fine today, this nice summer morning.
Absolutely. We hope you're all enjoying the nice summer weather as well. If you've been here before, you'll remember Dr. Robert Murphy is the Executive Director of the Havey Institute for Global Health and the John Philip Fair Professor of Infectious Diseases here at Northwestern's Feinberg School of Medicine. He answers your COVID, public disease, and public health, infectious disease questions each week here on our Havey Instagram or Facebook, owned by Instagram, different app, YouTube, and we also answer questions submitted through email down below the video and on our Facebook page. So please, if you have a question, submit it at globalhealthinstitute@northwestern.edu. Today is July 20th, and Dr. Murphy will be reacting to headlines and answering your submitted questions through today. Starting with some COVID statistics for the United States, average new cases per day are around 10,000. Average new hospitalizations per day were around 889. Average new COVID deaths per day were 15, and new booster proportion is staying steady at 17%. Dr. Murphy, do you have any reactions to those numbers?
Well, they're all continuing on the same trajectory that we've been talking about, and that the hard numbers that we can follow now are hospitalizations and deaths, and they continue to drift slowly downward. So this is terrific. We really don't know how many cases per day there are, but in our first story that we're going to talk about, we'll talk a little bit about what's going on, because there are some signals that the number of cases is maybe up a little bit. Now, whether those get sick enough to go in the hospital and maybe some of them will die, we don't know. So, but that's what's going to play out over the next couple of months.
Mm-hmm. And what are some of those early indicators?
Well, there are, the government, the CDC is following the hospitalizations and the death rate from the virus, but they also look at COVID levels within communities, and they look at wastewater tracking. They can tell if there's a lot in the wastewater that, maybe there's more in the community. And so the hospitalizations are going down, but several counties in Montana and southern Texas have reported high transmission levels, as well as several other counties in Texas, Kansas, and North Dakota showing medium levels of transmission. And emergency department visits, which can also be tracked, were up over 10% last week compared to the one before, with Alaska, Florida, and Hawaii reporting the highest percentages. So those numbers are going in the wrong direction. But we don't know how sick those people will get. We are seeing ourselves in our clinics here in Chicago. Cases are occurring, fairly steady and frequently. COVID has not gone away, but because of the availability of treatments like Paxlovid, an oral pill that you take twice a day you take 3 pills twice a day for 5 days, that works pretty good whether you're vaccinated or not, or whether you had COVID in the past or not. So, you put all that together, and that's dampening down the whole severe effect of the disease. So there's immunity, there's treatment, and there's good hospital care. The hospitals are not overwhelmed with COVID anymore. So you put all those factors together, and so these bad, serious outcomes like hospitalization and death, hopefully they're going to stay down, but we'll see.
Mm-hmm. Yes, definitely important to keep monitoring those. And as you mentioned, Paxlovid, that leads us into our first submitted question for the week. We have a patient who, is in the older age, has a couple of pre-existing conditions, and tested positive and is taking Paxlovid. Their doctor asked them to take or stop taking some of their medication during that time. Could you advise them when they could start taking, uh, for example, Simvastatin after completing the course of Paxlovid?
So Simvastatin and other statin drugs are used to treat high cholesterol. They're very commonly prescribed, and they're very important drugs. And when you Paxlovid is actually two medications in one, and the one component, the ritonavir component, actually is given strictly to stop the metabolism of the drug, of the other drug in the liver where it's metabolized, so that the level goes up high enough to really work well. Well, it also shoots up the level of some of these statins, especially Simvastatin. So while you're taking Paxlovid, you should not take those drugs. And the pharmacist should be telling you this, or your doctor should be telling you this before you go on it. And you should just not take those drugs for the time you're taking the Paxlovid. And there's actually some recommendations published out there from the NIH and the FDA that say that when you're done with the Paxlovid, you shouldn't start those drugs for 5 days. Now, there are some other cardiac drugs that are very sensitive to Paxlovid, and you really can't take Paxlovid. So there's a list of these. It's a little bit long to go in here, to talk about here, but the pharmacist and your doctor should know about those interactions. There is an alternative for you, molnupiravir. It doesn't work as good. We talked about this before. It's very unclear how effective it is, but it is an antiviral and it has shown some benefit in certain situations. So you do have an alternative if you have to stay on whatever drug it is that's having that interaction. But it brings up the whole issue of, do we have enough drugs to treat COVID if COVID is going to be around forever? And the answer is no, we need more. And there's several that are in development and that may not have those drug-drug interactions. So, and then as diseases are chronic and the drugs are continued to be used, you always worry about resistance. Now, we haven't seen any resistance to either of those two drugs. Another issue with molnupiravir, the second drug, pregnant women and breastfeeding women are not supposed to take it because there are some issues with the fetus that are theoretical, but it's theoretical as possible. So, they're not supposed to take it. So there's issues with every drug out there. So we do need more drugs, and maybe in the future, we're going to need combinations of drugs.
Yeah, that's very interesting. I rarely am thinking about the chemical interactions that may occur between different drugs. So it's obviously very important.
The good news is you're only talking about 5 days of treatment. So, there are ways to get around it, but you've got to be careful. You can't just be cavalier about it.
Absolutely. And moving on to our next submitted question, we get a lot of questions about specific situations with boosters. So we try to be selective about how many we can answer per week, but this one is a pretty great situation. So we have a couple that is, again, in the older age group and are going on a domestic cruise, nice vacation situation this August. They've heard your recommendations about waiting for the monovalent, but are unsure if that will be available before their trip, and would wonder if you recommended just getting that extra bivalent dose just in case and then waiting.
Okay, this is a high risk group because of their age, although they're not saying they have any severe underlying disease. So that's really good. We don't know if they had COVID in the past. That would also be helpful. And it's a great question because there's no one answer that's really correct. However, because of their age and because they are going to be mingling on a boat, which really puts people in tight quarters, even though it's a boat and there's air going by outside as the boat goes and whatever like that. Boats are notorious for transmitting infectious diseases like COVID, like flu, like norovirus, the viruses that causes diarrhea on some of these cruises you've heard about. So I would say that since they had their booster in early September, go ahead and get another booster before you go of the current one that's available. Then when you get back, wait 4 to 6 months and get the new one. Then you're sure that you're going to be as protected as possible. And if you do get sick, you take the Paxlovid because these people are eligible for that because of the age.
Mhm. Yes. And even historically, thinking back about, smallpox, the Black Death, all these historical diseases that have traveled on boats. That's a really great point. I did not think of it first. But transitioning into our headlines for the week, there's a very important announcement from the Biden administration confirming and announcing that they would provide free COVID vaccines through a certain period of time. Can you give us a little bit more information on specifically who that was for and what that means?
Yeah, so the United States bought everybody's vaccine until the pandemic officially ended on, I think, May 11th. And now it's a hodgepodge of insurance companies, government entities supplying these things. Now, a lot of people did not take the recent booster that came out in September 2022. So they have stockpiles of this stuff. So they are providing it free to uninsured people. It would be nice if they just say, oh, we'll just give it out, but they're going to give it to the uninsured. And there's still a lot of uninsured people in the United States, 20 to 30 million. Now, this does not include Medicaid, many insurance companies, Medicare, all these other funding agencies should be funding these vaccines, but it's such a hodgepodge. It's very difficult to even talk about because there's so many different ways you can get funded. But the biggest risk group is people with no insurance, and these people can now get it through this bridge access program, and they have them. They're out there. They're sitting in a warehouse, and they're going to expire. So people should take it.
Absolutely. And moving on, there was a great study published by researchers here from Northwestern, actually, about the lingering effects of long COVID, even as, like you mentioned, we've been seeing hospital numbers decline. Can you give us a little more info on that study?
Yeah, Northwestern, started by Igor Koralnik and the neurology department here, has been following a very large cohort of people, some 1,800 people, and they have found in their data that a third of them may be suffering from long COVID. All right, they have some kind of symptoms, and they have all sorts of symptoms, and they have abnormalities. They have 83% of them had an abnormal chest scan, not just an x-ray, but a scan. 85% had a decreased quality of life. 12% had problems with the heart rate, and all sorts of other things. Now, this is not a population-based study that's just kind of out there. Those studies have shown that the long COVID rate is around 7%. But this is kind of a group that's somewhat selected, so the number is higher. So that's not 1/3 out of everybody who gets COVID. But still, of the ones that are showing up at the hospital with some kind of symptoms or are concerned about it, it's a third. But it just shows you that, and some of these people are young, and some of these people have been, unable to work, at high level jobs, and they have problems with the cognitive thinking, and but I mean, it's all walks of life could get this. People, too tired to work, or they've got headaches or dizzy, whatever. So it's debilitating. The good news is that most of these people do get better with time. We don't have a specific treatment for long COVID, because long COVID is this whole spectrum of diseases. But some of the symptoms of long COVID can be treated. So, a good doctor or clinic should be able to take care of at least some of them and monitor you until your symptoms improve enough that you can get back to somewhat of a normal life. But it's a very serious problem, and it's being looked at more closely now. But we still don't have an answer to why some people get long COVID, or to how long it's going to last. Or is there any specific treatment? Those we don't know yet.
Absolutely. And those are topics that we will keep researching and keep you updated on, our viewers.
It's just another good reason to keep up with your vaccines so you don't get COVID in the first place. You don't get COVID in the first place, you don't get long COVID. So that's the reason why, the biggest reason now, because the treatments are so good that you don't want to get COVID no matter what.
Absolutely. And speaking about treatment and expansion of treatments, there was a recent announcement that Johnson & Johnson is going to expand global access to a TB drug that they have had a patent on for some time. And there's been, kind of a lot of muss and fuss in the media surrounding it. So I'd love to hear your perspective.
Yeah, J&J has this TB drug, Vidalaquine, or Vidalaquin, some people call it. And they've had it for a long time. And, the patent is supposed to come up, but companies can do things with their patent to make it go longer. And so but since TB is a drug that's predominantly occurring in lower and middle income countries and is particularly dangerous in people who are also infected with HIV. It is a debilitating disease and life-threatening. In 2021, over 1.5 million people died from tuberculosis. It's the #1 infectious disease killer in the world. Compared to HIV/AIDS now, it's 650,000 deaths per year. That's, it's an enormous number, but TB is almost 3 times that much. So TB is really bad. We've made very slow progress in treating it over the years. Some 10 million people a year are getting sick with it. If you look back at the beginning of the AIDS epidemic in the early 2000s, 2 million people a year were dying from HIV/AIDS. But that number has come down, as I said, to 650,000, and hopefully will continue to go down. So anyhow, this drug, Vidalaquine, was first approved in 2012, and it really revolutionized the treatment for drug-resistant infections, which is a big problem in treating TB, and one of the reasons why they die. But, it was priced at $900 per course. And with the number of people and the income of the people that are getting TB, it is not being used enough. And the price has gradually been lowered to $340. And a deal was reached with a Swiss nonprofit manufacturer to get a generic version out there. And the nonprofit is hosted by the United Nations Office for Project Services. And so there's many advocates like Doctors Without Borders, Partners in Health, Stop TB Partnership, and a lot of celebrities are out there. Author John Green is one of the ones that is promoting all this, and they're trying to get J&J not to extend the patent. And to show you how impactful it is, if you include Vidalaquine for the 6 months of the treatment in TB, there's a 78% culture conversion. In other words, the TB culture in your body turns from positive to negative, and that is typically a marker for treatment success and better survival. Maybe as many as 1 million people, if it was really utilized, could be saved with this drug. So that's like big news now, and hopefully that's going to happen.
Absolutely.
And be developed, hopefully. Mm-hmm.
And again, speaking of drugs that could help save a lot of lives, there is a new drug that was just approved to protect babies and toddlers from RSV that just got FDA approval. If you could shed a little light on that one for us. Yeah, so RSV, I would say the general public a couple of years ago never heard of RSV. They're just like, whoop, we would see RSV infection, particularly in transplant patients and really sick patients with cancers and the like. The pediatricians are very well aware of it, because infants in particular are very susceptible to it, and it's one of the
leading causes of death of young children and hospitalizations for sure. So in May 3rd and May 31st, 2 vaccines were approved by the FDA. Amazing. And they're for adults. So 60 and over, particularly if you have an underlying disease, some 10,000 people a year can die from respiratory syncytial virus. So it's a serious thing. But if you look at children, 2.1 million outpatient visits per year, that's a lot. 58 to 80,000 hospitalizations in children under 5. 1 to 300 deaths in children under 5. So, children, this is a lot for kids, because kids otherwise, do really well with everything almost, if they're treated appropriately. But that also is associated with 60 to 160,000 hospitalizations among adults 65 and over, and these up to 10,000 deaths per year in adults 65 or over. So the vaccine, of course, is not going to, won't be effective in these children, and it's not approved in the children yet, but this monoclonal antibody is. So it's given, I believe it's very well tolerated, and I think it lasts for up to 6 months, if I'm correct on that. There's an older drug that's available, but it has to be given monthly, so it's very inconvenient. So this prevents it, and it will protect babies at risk. So it's a big step forward, and hopefully we'll see more improvement there, because those hospitalizations, I don't know if you remember, a few months back, it wasn't that long ago, that the ICU beds in almost every pediatric ward were filled with kids with RSV. So it's not, 1 to 300 deaths per year is bad enough, but up to 80,000 hospitalizations, that's huge. There's just not that many pediatric beds these days. A lot of them have consolidated, and many hospitals, had a few pediatric beds, but they've closed them now. So it's been really problematic for little kids and toddlers. And so this is just another weapon that we have to treat a very serious disease in young kids.
Absolutely. That's scary news and great news to hear that more things are in development to try to solve some of these issues.
This has been a huge year for RSV.
And lastly, we're going to bring it back to COVID for our last story here. There was a very, very interesting study posted and published, about a possible genetic or gene variant reason that people are asymptomatic when they get COVID. Can you kind of explain that to us and break it down?
Well, with many diseases, some people get really sick and die, and some people don't. Well, we know age is associated with it. Sometimes it's sex, men do worse or women do worse, whatever it is. But with COVID, a lot of people really didn't get that sick. You'd have family members, one person got real sick, one person didn't get sick, whatever, or people in school, whatever it is. Some people really got sick and some people didn't. So anyhow, in Nature, which is one of the most important scientific journals, this is just yesterday, a research team looked at 30,000 bone marrow donors where they had really high quality genetic data, and they were asked to check COVID symptoms on their smartphones throughout the study duration. And over the course of the study, 1,428 unvaccinated individuals tested positive, and 136 were asymptomatic. And the key finding is those that had the HLA 1501 allele, genetic marker, and those, you can either have 1 or 2, and especially those that had 2 copies of that variant were more than 8 times more likely to remain asymptomatic than those carrying the other HLA variants. So this is really important, because it's going to tell us the mechanism, or it points to the mechanism why some people really get sick and some people don't. So this is a great study. This is just the beginning of looking at the genetic, the impact of genetics on disease presentation.
Absolutely. And I thought it was really interesting that their final study cohort was unvaccinated individuals. Do you think that gives, a clearer scientific idea of, just the pure virus, how it's acting because those people do not have any additional antibodies or
this goes back for a while. So a lot of people were not vaccinated. So yeah, this is really kind of talks about the natural history, without the impact of the vaccines. So it's a very important study, and remains to be seen, how this plays out, how we look at this in the future, to find out, because maybe some people, if they have this allele, they maybe need not to be vaccinated or not to be vaccinated as often, or, whatever. And how many people have this allele in the general population? In their study, it was 20% carried it. But I mean, if you look at real population-based studies, we'll find out a lot more about this. This is just the beginning, but I think it's very exciting scientific news.
Absolutely. We will keep up to date on that and make sure that we will catch any new research coming out about the subject. I'd like to thank you again, Dr. Murphy, for your time and expertise. We really appreciate you reacting to the headlines and answering our viewers' questions.
Well, thank you.
All righty. Thanks, everyone. Thank you for watching this week's episode. Again, please feel free to submit your questions below on our YouTube page. Email us. All of our links are in the description below, and we love to hear from you. Thank you.